Okay, I'm recording right now. Good morning, actually good afternoon or good evening to everyone. This is our SBRT and SRT remote training number 4. If you missed the first, one of the first 3 training sessions, Geneva should have sent you the recording so you can watch the video if you want. So today we are going to have training session number 4. So you probably have received multiple emails from Geneva. Please complete your survey. And also in the meantime, I'm going to send a message about the registration. If you complete 5 of the 6 training sessions through us, you will receive a certificate. And in total, we have 6 training sessions. And in the last few weeks, we talk about the brain, SRS, SPRT. And the second session, we'll talk about prostate, bone mass. And last week, we talked about lung, spine. Today, we're going to focus on liver and pancreas using SBRT. Today, we have 2 speakers from Baylor College of Medicine. Dr. Hanania is one of our medical director at Smith Clinic. He received doctorate degree in medicine from University of Texas in Houston. And then later on, he came to us at Baylor College of Medicine. He completed the rest of the training in radiation oncology, and he stayed here as a faculty. Dr. Lafratta is one of our medical physicists, and she received her PhD from MD Anderson in 2015. Since then, she became medical physicist and faculty with us. And currently, she is the lead physicist at one of our sites. So, Dr. Hanania, are you ready?
Yes, good morning, everybody. Hopefully you can hear me.
You can share your screen.
Okay. Okay. Well, thank you, Dr. Sun, for the invitation to speak this morning. And I'm just going to present a little bit on really ablative radiation topics in GI cancers. Because one thing that I'll touch on a few times in this talk is that, at least in the United States, SBRT has a very kind of narrow definition, requiring 5 treatments or fewer. But what I hope you'll see is that in many cases, that might not be feasible, but we can still give a dose-escalated treatment in a more fractionated setting, akin to SBRT. So at any time, if you need me to clarify something, please feel free to leave something in the chat or raise your hand, and hopefully I will see it, or Dr. Sun will see it. Otherwise, I think we'll have a dedicated time for Q&A at the end for more discussion.
Actually, I forgot to introduce Dr. Abdana, and he's one of the doctors here. I invited him to join this session so he can answer the questions through chat. So feel free to type your question. In this way, we'll not interrupt speakers. Thanks.
Perfect. Okay. So let's get right into it. So I was going to start with pancreatic cancer. In the United States, this is the 4th leading cause of cancer death. And so it is a major problem that's only, we've only removed the envelope only very slightly in this disease. And generally speaking, when we think of pancreatic cancer, we generally think that the patients likely harbor micrometastases at diagnosis, and their survival is mostly thought to be limited by their systemic control, which is generally chemotherapy limited. That being said, there's really mortality in this disease secondary to 2 mechanisms. While the majority is early metastatic spread, there is about 30% of cases when studies are done via autopsy that show death due to essentially local morbidity or local progression. So it is not a disease where every single patient dies from a metastatic disease. So local control in pancreatic cancer is actually quite important. And in fact, there are even genetic variants that have been discovered that tend to be more locally aggressive than they are metastatic at presentation. So it is important that we continue to strive towards good local therapies in patients with pancreatic cancer. However, good selection is also necessary because we do know that most patients probably don't always benefit from radiation. In fact, historically, trials that compare chemoradiation to chemo alone, have not shown survival benefit. But there are a lot of issues with these trials. One is that if our chemotherapy is inferior, then patients will not live long enough to see the benefits of local therapy. So as the chemotherapies that we have improve and as survival improves because the patients do not develop metastatic disease, then radiation becomes more important. And the other issue is that standard doses of radiation that are given conventionally generally max out around 50 to 54 gray. And so this dose of radiation, the thought is, might not be enough to actually, prevent progression of this disease without a surgery. So the two paradigm shifts are, and again, just very briefly here so we can talk about some cases, improving systemic therapy, which is an easy one to implement once chemotherapy trials come out and they're positive. And then the harder one is escalating radiation treatment and using advanced technologies to do so. But I'm hopefully going to show you that you don't necessarily need, any very expensive machine to do some of this type of treatment. You just need to be very thoughtful and select patients, only pick well-selected patients for dose escalation with radiation. So what is radiation's role? It is the most studied and effective local therapy option in locally advanced pancreatic cancer. So in patients who can't get surgery, we really are the only true local therapy that exists. And in patients who can get surgery, it's best to give the radiation before surgery for many different reasons, but the vasculature is not disrupted. We decrease the chance of a positive margin and a local recurrence, and we improve the likelihood that they will not have involved lymph nodes at the time of surgery, and they're more likely to finish the course if they get the radiation before surgery. But we're going to focus on the cases generally who can't go to surgery, because that's usually when they are sent, at least in the United States, for radiation. And in the US, if patients are resectable, they usually get chemotherapy and surgery, and radiation is only reserved for positive margins, sometimes for PNI or other risk factors after surgery. This is my general professional opinion. So keep in mind that in this disease there is not always a right or wrong answer. But what I would say is that pancreatic cancers really differ from patient to patient. And so we really do need better tests to select based on molecular characterization who's going to benefit from radiation. The patients must survive long-term for the benefits of our therapy to be realized. So if they're not responding to chemo, that's not a patient who's going to benefit from the radiation, generally speaking. And the trials that do exist have not really been designed in a way where they're evaluating radiation. Usually they're evaluating chemo, and there might be, an arm that's looking at radiation, but they're not randomizing and restaging the patient right before radiation treatment. And so the problem with that is in many of the trials, they've included patients who have metastatic disease even before they get radiation treatment. And so we do have a trial that's opening in the United States soon in 2025. That's going to be a pure radiation escalation trial where they restage the patient and randomize before escalated dose radiation. And I'm very excited about that, but it's going to be years before we have a great answer for whether or not we have level 1 evidence for dose escalation. But if you look at pancreatic cancer, there's very few other cancers where surgeons get an R1 resection after surgery. And R1 for the trainees on the call means that there's a microscopically positive margin. So there's generally a concern that there's been some disease left behind that the surgeon could not see because it's not macroscopic, it's not gross disease. In the borderline resectable population, we know chemoradiation certainly helps these patients by improving the rate of an R0 resection, progression-free survival, and in select patients, probably overall survival. In general, when I have patients who cannot get surgery, I always favor trying to get them as much chemotherapy as they can tolerate without, too much harm, because really the number one benefit is still the chemotherapy. But once they have exhausted that, that's when we talk about what we can do with radiation. Not every patient is going to be a good patient to escalate the dose. And in my practice, a 3-week course of radiation, which is only mildly hypofractionated, is very tolerable with concurrent Xeloda. And this is a preoperative dose, but in a patient who's not a good patient for dose escalation, can also be a reasonable dose to give for local control, that's done outside of surgery as well. If the patient's not getting surgery, sometimes I might boost the primary tumor to 40 gray in that 15 fraction regimen as well. But if the patient is unresectable, they have not progressed, and what's not in here is they have favorable anatomy, then I think it is very reasonable to evaluate that patient for more definitive or ablative radiation. Keeping in mind, many will not qualify based solely on the anatomic constraints and the disease constraints. And before we go further, one thing I want to talk about is the biologically effective dose and the different fractionation regimens that are used and how those differ in the clinical effect that we might see. So what many are familiar with are conventional fractionations, which are generally given at 1.8 to 2 gray per day. And usually we're stopping around 54 gray because of classical duodenal constraints. And you can see the BED calculation there, 63.7. That number doesn't mean too much on its own, but it's used as a way to compare between different fractionation regimens. The 36 and 15 approach, which is a preoperative dose, but again, can also be good for local control in patients who may not be eligible for, again, dose escalation, is less than what you would get with the 54 gray and 30 fractions. But this is a very convenient 3-week course for patients, especially if they cannot be under treatment for 6 weeks. And with Xeloda, it's very well tolerated despite the fraction size being slightly larger at 2.4. Now, the one fractionation regimen that we'll see sometimes referred to in the literature as SBRT, but it's not really SPRT in the fact that it's not ablative. And this has confused medical oncologists, it's confused patients. But this 25 and 5 is really a palliative course. We often don't use this with Xeloda, and I usually use this for patients where they just need quick palliation. And these are 5 gray per day fat fractions given sequentially, but you can see the biological effective dose is lower than the other 2 regimens. Still useful, but this is not what I would classify as a very strong regimen as far as durability of local control. So moving from there to what the dose escalated regimens that are often used are. Probably classically SBRT, and defined in the US as 5 fractions or less, is going to be something around the lines of 50 and 5, 45 and 5, 40 and 5. You can see now the fraction size is much larger. The biological equivalent dose is at 100. And this is, again, with the alpha, I didn't mention before, but this is based on an alpha beta of tumor at 10. Okay, so that's why that subscript 10 is there. So this is generally, when we see, say, a BED of 100, that's generally what we're talking about for ablative doses. But you may not always be able to get that in 5 fractions because of dose constraint limitations. So what are the other options? So These other regimens, which are in the US not classified as SBRT, though we plan them very similar to SBRT, and we just basically do a little bit less each day, but we still get to the same biological effective dose, 67.5 and 15 fractions, and 75 gray and 25 fractions, you can see are getting quite close to the VED that we're getting with 50 and 5. And the nice thing about these regimens is the dose constraints are much more relaxed. And so it's much more feasible to be able to attain these doses on a linear accelerator equipped with simply a cone beam CT, and not necessarily an MR-Linac or a CyberKnife or any type of real-time KV imaging. So all that fancy technology is not necessarily needed, as long as when we use these fractionated regimens, we're very careful about the planning, which I'll get into. And then, yeah, okay. So this is a paper by Dr. Crane, who's now at Sloan Kettering, but was at MD Anderson before that, kind of explaining this idea of a simultaneous integrated boost. And the simultaneous integrated boost, or the SIB, is the idea that into the tumor, we put a maximal dose. This dose is not necessarily going to the entire tumor because it is limited by the structures nearby. So in this particular figure, what you see here is that the tumor is here, but the patient's duodenum is here, the stomach is here, jejunum, uninvolved colon, and the dose that's getting, this heterogeneity, in this case 98 gray, is very focused, and it's actually not even encompassing the full tumor. But there is a fall off that happens, and the idea is that you're getting a very high dose to the core of the tumor, hopefully to where the hypoxic cells are. And there's a fall off that happens from there. And so the concept of these plans is a little bit different than thinking about radiation treatment conventionally, because that high dose that we talk about is not always going to the entire tumor. It's going to a part of the tumor, generally speaking, inside of your target volume, inside of your PCV. And, this evolved out of work that really suggested, are our conventional doses, 45 to 54 and, 5 to 6 weeks of treatment really enough? And we know that with adenocarcinoma, we do not cure doses at 54 gray and 30 fractions. We really do need VEDs closer to 100. And this has been shown in different GI cancers that are adenocarcinomas. And so unlike squamous cell carcinomas, where we can potentially achieve a complete response with a lower dose with concurrent chemotherapy, with adenocarcinomas outside of surgery, we need a higher dose. And the problem too, and the reason that all the conventional doses were so limited, is because if you look at, the toxicity to intestine and to liver, they're really around these doses. And these are the risk of, in 5 years having a 5% injury, or 50% of the population that you treated having an injury. So you can see how quickly you go from 5% risk to 50% risk in 5 years as you increase the doses. But the problem really is field size. So we were treating a large amount of the organs with these doses. And now with more sophisticated targeting and IGRT, image-guided radiation, we can be more precise with the volume of radiation that we're using. So one paper that I'm going to reference moving forward is a paper that I worked on during training with a lot of kind of GI experts regarding this SIB approach to pancreatic cancer. But there are a lot of different papers that support this practice. In the US, we use the NCCN guidelines. and those are used by, radiation oncologists throughout the whole country. And there's a lot of support to do this. So it's not just my opinion, but it's many people's thoughts that this is something that is reasonable to do for well-selected patients with pancreatic cancer. Okay, so here's a case of a patient who's 60 years old, who is diagnosed with pancreatic adenocarcinoma in the pancreatic body, highlighted out here in this red contour. This particular patient was otherwise fairly healthy apart from some abnormal liver function tests. They went on to receive 8 cycles of FOLFIRINOX and had an excellent clinical response. The tumor decreased in size with chemotherapy. They did not develop any other metastatic disease, but unfortunately, they were deemed ineligible for surgery. And there was too much involvement of the common hepatic artery and the origin of the splenic artery in this particular patient. So a lot of times we'll see vascular involvement as precluding patients to get to surgery. So for this patient, what we end up doing is contouring the tumor, which is red GTV, and then contouring the vessels in blue where the tumor was adherent. And we create a volume structure called the TVI in addition to the GTV, which is in green. And this is called the tumor-vessel interface. And the idea is, in patients who might be they're unresectable currently, but perhaps they could become resectable, to make sure that you're also treating where the tumor is stuck to the vessel in an effort to help the surgeons with a potential resection in the future if that were to become a possibility. I will say these days, I'm careful about not dose escalating patients who might go to surgery because you can't complicate the surgeon's anastomosis. So you really, if you're going to do anything apart from conventional radiation for a patient who might go to surgery, you need to have a discussion with the surgeon about the likelihood of surgery and, the technical aspects of the anastomosis, so you do not compromise their ability to do that if the patient goes to surgery. So after we contour the targets, again, the GTV, the tumor, and the tumor-vessel interface, the other important thing is to contour the bowel. If you have 40 CT, then what you want to do is contour the bowel over a period of time with respiration. And then with the bowel, we also add 5 to 7 millimeter structure to the bowel and the stomach and the duodenum, which is here in black. And we create a PRV, which is a protection structure for the organs at risk that we will use in the dose planning calculations. Okay, so this particular patient's plan, I want to highlight here. So this patient did get SBRT, 50 gray and 5 fractions. And what you can see is the prescription isodose line in red, and the tumor is in black. And the vessel is also in black here. You can see that the 50 gray isodose line does not cover the tumor completely, because in our planning, we actually use the bowel PRV that we created off of the duodenum and the bowel structures to limit the dose and create a gradient here. So we don't want to completely underdose near the bowel, but we have a gradient. So 40 and 5 is almost covering the whole tumor with margin, but 50 and 5 is right over the more central part of the tumor. And then our dose fall off is very rapid. So this is the 25 gray isodose line that's falling into the duodenum and bowel. And you can see that that's also very conformal. So very, very little bowel is being exposed to that. So the patients generally have pretty minimal side effects. Here you can see where the duodenum, there's the C loop of the duodenum, and so you have a duodenum on both sides that you need to account for. The tumor is kind of, in this particular case, right in the middle as we go down to treat the vessel interface, and we continue to kind of wrap dose around the duodenum. I'm going to skip this slide. You can find it in that paper, just like who's a good candidate for inclusion The big thing is you want to avoid patients who have direct involvement of the duodenum or direct invasion of the duodenum by tumor. Those are not going to be patients that are suitable for dose escalation because of the risk of a sentinel bleed. And if you go to this paper, it will show you 5-fraction treatments, but also a 15-fraction regimen that you can also do. And here you can see that there are generally two volumes. So for PTV, so for the 15-fraction regimen and for the 5-fraction regimen, let's start with the 5-fraction here. There's a 33 gray volume for microscopic disease control that you'll make sure that the whole tumor and tumor vessel interface gets full coverage. But then there's the PTV high, and it's demarcated with the Z in front of it because it's planning structure really to push dose into the tumor. And on this particular structure and dose to 50 gray, we may not get these coverage goals, and that's okay. We want to make sure to always get the low dose coverage goal, and then we do what we can here. But you can see this planning structure is the tumor and tumor vessel interface with a little bit of margin, 3 millimeters here, subtracted by that PRV structure off the bowel. And so it's going to be cropped in many cases outside of the whole tumor. It's going to be a core of the tumor that you end up with that you're dose escalating. And so if you can't do it in 5-fraction because the dose constraints are too rigid, then you can do that in 15 fractions. And the regimen is a lot easier to get a passable plan. And not in this paper is a 25-fraction regimen, which is also a great option and one that I use quite often in more challenging cases. For the sake of time, I'm also going to skip over this, but there are things you want to do in your center to just make sure that you are able to deliver dose escalated stereotactic planned radiation appropriately. And I think Ryan could talk to that a little better than I can. But I would say 40 CT is absolutely a must, as is cone beam CT. I think those are 40 CT and cone beam are kind of the bare minimums for dose escalation. And ideally, too, you'll have some sort of respiratory motion management, and that can be as simple as an abdominal compression device, which is not terribly expensive. And in our county hospital, we use primarily abdominal compression as our respiratory management. I do have another pancreas case. I know that time-wise, I want to make sure that I give enough time for Ryan. So I can move straight to a liver case, Baozu, or what do you think?
You can go through that. You can quickly go through this case. No problem. We have time.
So this is another patient who was unresectable because they had full involvement of the superior mesenteric artery and the celiac axis. And so this patient, the tumor you can see here is not so much in the body, but more in the head. And pancreatic head cancers are usually right next to the duodenum, so very difficult to dose escalate. Generally, a 5-fraction regimen is not going to be possible. So this patient got a 15-fraction regimen. The GTV is contoured in red. And then in these IMRT cases, we generally will do a 1-centimeter expansion of the tumor and the celiac axis and the SMA. The duodenum is contoured here in black, so you can see it's very close. The stomach and bowel are also contoured. And then we make this bowel PRV structure again. We contour all the bowel, and you want to kind of focus closely on the bowel and the different parts of the 4D scan, and then make your PRV structure from there, as opposed to making just a bowel bag. And once we have that, we have our structures, so we can generate a plan, again, based on having a sub-volume that we're treating to a higher dose. So in this case, it's 15 fraction. We're treating 67.5 gray. And you can see the tumor here in black is being slightly underdosed of the full dose. But the lower dose microscopic control, which is 3750, is covering the entire CTV. So in this effort, we are doing 15 fractions, but we are doing really a stereo-like plan with heterogeneity focused in the core of the plan over at least part of the tumor, if not all of the tumor. And we're able to minimize the dose to the duodenum and bowel and make it a safe plan for the patient. It's very important, though, during your daily fractions that the cone beam is reviewed carefully and that you make sure that the bowel has not moved or migrated with gas or other motion to be inside of the higher dose PTV for any reason. So it does involve some education on the console of the radiation therapist to make sure that they are localizing the high dose volume to the correct location. Okay, so liver, historically, we were always afraid in radiation oncology to give too much dose to the liver for a very good reason, because if only 30 gray is in conventional treatment is given to the whole liver, we know that there's a percentage of those patients, 5 to 10%, who will develop this horrible radiation-induced liver disease, which can be fulminant. Nowadays, the reason that we can actually do dose-escalated ablative treatments of the liver is because we are treating a much more conformal focused plan, and we're avoiding the uninvolved liver. This slide is more for non-radiation oncologists, but it's just that, local therapies, they're not all the same. RFA is great for tumors 2 centimeters or less, but as you get larger, the control starts to fall off. Y90, which is a form of radiation that we deliver intravascularly, is a good option, especially for multifocal disease, but not always possible based on the patient's vascular anatomy. TACE is not ablative, though. That's when you just embolize the tumor, and is really not an oncologic therapy so much that it just buys time by helping decrease the blood flow to that lobe of the liver, but it is not going to get rid of the cancer. At some point, it's going to grow back. But let's focus on SBRT. So HCC is one of the more common ones that we treat in the liver, and it is a radiosensitive tumor. The 1 to 2 year local control is about 90%. And now we have phase 3 data from Dr. Dawson and Princess Margaret that supports the use of SPRT with a survival benefit for certain patients. And generally, if patients have a single site of disease and a tumor larger than 3 centimeters, that's going to be a good candidate for SPRT, assuming that there's no other unfavorable anatomy or challenges. We can also use SBRT for colorectal cancer metastases that go to the liver with very good control. I'm going to kind of skip over this for time purposes, but finally, we can also use dose-escalated radiation for large tumors in the liver, such as with intrahepatic cholangiocarcinoma, in a more fractionated way, generally speaking, usually after the patient has gotten a lot of systemic chemotherapy and is not a candidate for surgery. So generally speaking, for liver tumors, again, 2 centimeters or less, RFA is a good option. 3 centimeters or greater, we start to think about SBRT. Greater than 5 centimeters, we can still treat them with SBRT, but sometimes you have to limit the dose or you need to consider fractionation. And this is just a nice for patients to understand the sizes. Okay. Quickly, I just want you to know if you're treating liver cancers, this is an excellent paper to reference. And the reason why is because they show you the different regimens that you can use for dose escalation. And what you'll see is there are these ultra hypofractionated regimens, but you can also do these 15 fraction regimens and can even conventional fractionation if you need to. And the nice thing is that they provide dose constraints. Primarily what you want to focus on is uninvolved liver here. And they provide the constraints based on the patient's liver function. So this is Child-Pugh class A. This is a non-cirrhotic liver. This is class B7. I generally will not treat patients with a Child-Pugh class worse than B7, as whether or not they will bounce back their liver function after SBRT is very conditionally kind of questionable. So I usually will not treat patients who are Child-Pugh class B8 or higher. And then just so I can kind of finish off here, here's a patient that I treated most recently. They had a large single HCC. This is on a contrast scan, but when you go to plan, a lot of times on your cone beam, you're not going to have contrast. So it's helpful to have a fiducial placed. So our interventional radiologist placed this fiducial in the tumor for us. We used our planning based off of MRI and CT to design our target volume. And then I like to create a structure called a line fiducial in the 4DCT. I can't play this video for you right now, but that structure basically tells the therapist on the console to make sure the fiducial is within that structure to ensure that the patient's motion is being captured appropriately. I think this might play. Let's see. So there it is going up and down. And then here is the plan for that particular patient. And what you can see is that there's hot spots, a little hard to see, but heterogeneity kind of baked into the tumor. So in this particular patient, the tumor is getting like 120% of the dose, which is I would say kind of what you want to aim for, a minimum of 120% hotspot, if not more, in the tumor. And you really want your planner to be pushing hard off the uninvolved liver. So in these cases where you're treating near the dome, it's better to push dose into the lung than to push, to allow dose to fall off into the liver, because you want to spare as much uninvolved liver as possible. So in this case, we met all of our objectives. We also had to consider the chest wall here, like we do in lung cancers, because of the closeness to the periphery. But you do not want to spare tumor you do not want to underdose the PTV for the chest wall. So if that particular case happens where the chest wall dose is unacceptably high, then I'd consider fractionation rather than underdosing the tumor. Okay. Oh, and then this is the final case I wanted to show. Thanks for hanging in with this. This is a patient with intrahepatic cholangiocarcinoma, very large tumor, bowel right next to the tumor, which makes it super unfavorable for SBRT. Patient got chemotherapy, did not progress with metastatic disease. And then I was asked if we could give something more ablative or definitive. So what we ended up doing here, and I apologize for the audio in the background, I was watching sports when I recorded this. But you can see that there is this high dose that is planned into the center of the tumor. Let me see if I can get it to play again. And you can see the high dose is planned. And that's not necessarily going to the whole tumor. But what we're able to do is we're able to limit the dose to the bowel, which is very close by right here. Okay. So this is kind of what our directive to the planners look like. So the PTV 75 gray and 25 fractions, the coverage goal is reduced. And we're asking for SBRT like heterogeneity. So we want them to plan it like SBRT, even though it's IMRT. And then PTV 45 is the microscopic dose that we're giving. We want to get full coverage on that. So the priority for the high dose is not as high as it is for the lower dose. And then we have our dose constraints that we want to meet. And the most important one is really the uninvolved liver and the bowel. duodenum here. And then this constraint here gives people a lot of trouble, but this is minimum volume spared. So what that means is you need at least 700 cc's, if not more, of liver that is not getting 36 gray or higher. And even dosimetrists tend to get confused by this constraint. You need to look at the total liver volume, and then you need to look at the liver volume that's getting 36 gray or higher and subtract the two to actually get this number. And this particular patient, I just want you to see because I just saw him last week. He's 2 years after treatment. And this tumor actually became very necrotic. And over time, he had capsular retraction because he had a relatively healthy liver otherwise, since this was a cholangiocarcinoma. And the dead tumor retracted, there's capsular retraction, and it kind of resorbed on its own over time. And so you look at this patient's imaging, and it almost looks like he had a partial kind of segmentectomy or hepatectomy, and he has no evidence of disease currently. So, radiation can be very powerful. Some of these patients, potentially substituting or getting close to a surgical type of local control. And that's it for me. I'll go ahead and stop here, and sorry for running over time, Ryan. I don't know if we do questions together at the end or now.
Yeah, actually, if possible, can I answer a few questions? So on the chat, so multifocal liver lesions, would you recommend treating each lesion individual or address them all together?
Okay. So this is really where selection, proper selection of the patients is very important. So generally speaking, I would say most patients with multifocal liver mets or HCC are not the best candidates for radiation treatment if the goal is to treat all the disease. Because when you have more than one lesion, unless they're right next to each other, you're very quickly going to run onto exceeding your uninvolved liver constraints. And so it's not often practical sometimes to do simultaneous treatment. Sometimes in cases where maybe there's just two and one can be addressed with RFA or maybe surgery, but the other cannot, and then we can do SBRT to one of those. That's usually what I would favor. There are patients with non-cirrhotic livers, like with colorectal cancer mets, where I've treated one liver met and they come back in 6 to 9 months with a new one or a smaller one that I opted not to treat initially, and now it's grown, and I'll come back and treat that one after usually at least 6 months has passed, and I'll get LFTs and make sure that their liver function has remained good. But the thing is the liver function starts to fall off really at the 1 year mark. It doesn't fall off right away. So you have to follow the patients carefully, after 1 year to see the liver function potentially dip. And we usually quote patients very conservatively that, 30% of patients, their child's Pew class will go down by a letter after SBRT at 1 year. That's probably higher than what the truth is, but a lot of these patients have compromised liver function to begin with, and they're going to be undergoing other therapies that compromise their liver function. So you just want to be very attuned to what the patient's liver function is and how their synthetic function is prior to the first SPRT course. So there are cases where I'll treat more than one, but they're very limited. The best candidates are the ones who have a single focus of disease.
Before actually we move to Dr. Lafratta, we have one more question. How accurate can we depend on CBCT and motion tracking while doing a pancreatic SBRT 50/5 compared to using MR-Linac?
Yeah, this is a great question. And so, so at Baylor, we have 2 hospitals, and one hospital, where I'm primarily at, we only have cone beam CT and abdominal compression. We do have good plans and a Linac that can deliver a fast fall off of dose. But generally speaking, in those cases, I will only choose the cases that have really excellent anatomy where the tumor is very far away from bowel to decide to treat a 5 fraction, like 15/5 regimen. A lot of times it's not really possible. For most cases, it's not possible. So many of these patients I'm truly treating with 15 or 25 fractions because of that. But with a cone beam, I think doing 15, 25 fractions is very doable, especially 25 fractions. It's hard to run into problems with that. But what you should do is when you create those protection structures, the PRV structures, you should use an expansion that you're comfortable with at your center. So like in our paper, we may mention 5 millimeters, but at your particular center, if you feel that that is too rigid based on, daily cone beams and what you might expect, then you might want to use up to 1 centimeter of protection off of the bowel for the PRVs. That's to ensure that, with not having all those technologies, you're still able to deliver a safe plan. And, not all patients can come for 15 or 25 treatments. We're fully aware of that where we treat patients too. And in those cases, if you want to give a higher dose, unfortunately, you probably have to de-escalate the dose. And so I'd say very few patients get 50 and 5 if it's 5 fraction. More reasonable is 40 and 5. And in some cases, if you can't do that, then it might not be the best patient for dose escalation.
Okay, thank you very much. We have to move on to Dr. Lafratta. She will give a physics presentation. We have more questions. If you, Dr. Hanania or Abdana can help answer in the chat, that'd be great. Thank you. Hey, Ryan.
Good morning or good evening, depending on where you are. All right. Does everything look good and can everyone hear me?
Yes, it's great.
All right. So it's always great to follow Dr. Hanania. That was an excellent talk and excellent to follow. I am giving a liver and pancreas SBRT talk, but from more of the technical side. So I know at this point you've heard from several other physicists in the series who have gotten into some more detail. So I tried to keep this to some of the bigger picture items for successfully starting and maintaining a new SBRT program. So to begin, for stereotactic body radiation therapy, when I hear that, I immediately think we are going with extracranial tumors or tumors outside of the brain with a high dose per fraction. In my mind, that's from 6 to 30 gray in a hypofractionated regimen of 5 or fewer fractions. So the SBRT is mostly applied to tumors that are in the spine, lung, prostate, GYN, and today we're focusing on liver and pancreas, or the abdominal area. So the technical aspects of SBRT that I always keep in my mind when we're doing this is first, patient immobilization and motion control. So the margins for a treated volume for any patient can be reduced with robust immobilization, and if the target motion can be controlled. When we're talking about the liver and the pancreas and anything in the abdomen, internal and respiratory motion must be accounted for. It's not something we can ignore. The second thing you have to do is what's the difference here in the physics and dosimetry from a typical patient. Here we want a very tight conformality of the prescribed isodose line. We're going to want to pull in those margins as much as possible. And we're going to want a very steep dose gradient to minimize this high dose spillage to all of the surrounding tissues. And last, what do we need for the treatment delivery? And here it really does require onboard imaging for image guidance and patient positioning. I agree with Dr. Hanania. You really do need a cone beam CT for these ultra high doses. And it's going to require really thorough quality assurance for your patient positioning, both the device, the couch motion, anything else you're going to have in the path of the beam, and then for dose delivery. So let's talk first about patient immobilization. So there's a lot of different ways to successfully immobilize a patient for SBRT. At my treatment site, we immobilize all of our GI SBRT in a VacLock bag. That is a body-size bag. It goes down to the knees, up on a wing board with the patient's arms up above their head if possible, both arms if possible. Sometimes the patients can't. A wedge up under their knees to help immobilize the legs. And we also use compression if it's tolerated by the patient. There's different devices that can be used, vendor supply of stereotactic frames. One we have in this department is a Civco body ProLock here. So you can see there is the wing board. This has its own abdominal compression plate. It's compressing the legs down. There's a place for the feet. It's not what we like to use always, but we do have it. The big thing with any immobilization device or whatever you're able to get into your department is these devices should be carefully indexed to the table. It needs to be recorded exactly what happened at simulation to happen at treatment. We do this both in writing, and we also take pictures and upload that to our record and verify system for the treatment therapist for reproducibility. I've said this once, for liver and pancreas, internal motion must be considered. So there's options for both simulation and treatment. And the first and foremost is you need a good 4D CT for motion. It is necessary to know the extent of the internal motion of not only the tumor, but also all of the organs surrounding the tumor. Everything is moving with every breath these patients take. There are several tools that you can use to limit the motion. Compression is an easy one. It's what we like to use here. Breath holds, either a deep inhalation or what I call a normal exhalation treatment. And by normal exhalation, I mean take a deep breath in, let it out, and hold. Hold there. Patients can actually tolerate that very well. You can also give your treatments with a gated treatment, and I'll talk about that a little later. And if it's something that is available to you, place prior to simulation some fiducial markers for tracking. And fiducial markers can be very, very helpful if your image guidance quality, if your cone beam is not so easy to see a pancreas, but if you can have a fiducial somewhere near where you're treating, if not where you are treating, you would have something for the therapist to track. So when you go to the management of respiratory motion, the first thing you have to go, is this patient eligible for motion management? And it's unfortunate, but not every patient is. So this is a really good flow chart from AAPM-TG 76. It's old, but it works. And the first one is, do you have a method readily available? Do you have 4D CT? And if you don't, we need to start over. We need to find that solution. But as you move down this respiratory motion, go look, hey, is my tumor motion significant? When I took my 4D CT and I evaluated it, is the tumor moving more than 5 millimeters? Or conversely, even if it's not moving very much, could I spare more normal tissue if I were to control the motion? And you just move down this flow chart kind of going, okay, yeah, I still need to account for this tumor motion. So do I have respiratory management? Can I do a compression? Do I have a way to visualize breath holds and confirm that the patient's holding their breath at the same level as simulation? Can we achieve our clinical goals? And so you move down and you decide, I want respiratory motion and my patient can comply. And what do I mean by the patient complying? Go back and remember how we take a 4D CT. So this is an image straight from Kahn et al., the Bible here in the USA for the physics of radiation therapy. Looking at an object here, it's a circle, moving through 2 breathing cycles. And it's also being scanned with axial slices. So you see this gray circle, it's moving with the tumor, moving with the breathing cycle, and the black line is those axial slices. And as you reconstruct this coronal image, it's not equal to the real shape. Sorry that the not, the very important word, got cut off there. But you see, as you stack the slices, that coronal image doesn't look like your real shape. And that's something you see often in a motion management in a 4D at the dome of the liver. So this is something you're going to see if you do a free breathing scan without taking a 4D scan, that the liver just kind of looks like it got chopped, and then there's air, and then there it is again. So by using a 4D CT, this takes some software and it correlates the breathing motion of a patient to the CT image. And the example I'm going to use is the Varian RGSC system. This is what we have. It's a block that we place on the abdomen of the patient. It has infrared markers. We place this block halfway between the umbilicus and the xiphoid process, and by that, I just mean the center of the abdomen, where there is the most motion. There's a camera mounted in the room that tracks the motion of this box, and it creates that sinusoidal breathing trace. So we can, using software, connect that breathing trace to the acquired system, and you assign a phase of each axial slice in a process that is called binning. So typically bins are either phase-based if you're taking a 4D CT, or an amplitude-based if you're doing an inhalation or an exhalation scan. So after you bin all the images, you create the movies. Dr. Hanania showed one, and you can see this 3D image moving in time, and that's where the fourth dimension comes in, or a 4D CT. So not only do we reconstruct the 3D moving with image, we can also reconstruct the MIP, or the maximum intensity projection. It's your highest intensity value observed in a voxel, very helpful in thoracic. The minute, minimum intensity projection, that's your lowest intensity value observed in a voxel. It's very useful in liver. And also the average, and that's the average Hounsfield unit you find in each voxel over this. Now, it's preferable to calculate using an average scan, but the border of the tumor is not going to be delineated well. So you want to, if you're contouring on these patients, to use the individual phases, use your MINIP, use your things, but don't just contour your tumor on the average. We take a free breathing for every patient along with a 4D CT. If a 4D CT isn't going to work, or for us, we use compression, I'll get there. Breath hold's another option. So you want to have the patient hold their breath during simulation. They will also hold their breath during treatment. Typically, when you talk about breath holds, we're talking about a deep inspiration that would create a distance between the left breast and the heart. Normal exhalation can also be used for motion control. Patients tolerate this exhalation for a longer time. They can hold that for 20 to 30 seconds sometimes, and that's going to give you a faster treatment. You can use the same technology that you have for 4D CT, or if it's available to you, surface guidance technology that you're using in simulation. But if you're going to start doing a breath hold, you also need technology at the treatment machine as well. You want to match your breath hold at sim and treatment within a certain margin. We use a 5 millimeter breath hold margin. That's a very typical standard margin in the US. Some patients are not able to hold their breath long enough for simulation or treatment. You want to have them practice a breath hold to make sure they can hit the same mark every time you tell them. You want them to practice holding their breath for at least 20 to 30 seconds before you even take the scan. And if they can't do this, they're not a candidate. And you don't want to create a whole treatment plan and get them on the table and just realize we cannot treat. And then also look at your breath hold scans and go, ooh, did this really improve the plan? Do I need it? You're gonna want it mostly. But realize when you use a breath hold, it's a loss of efficiency and it's a longer treatment time. Just account for it when you're scheduling your patients in your clinic. The last one I want to talk about is compression, and this is what we use at our site as well. Compression belts or tools are typically placed over the abdomen to limit the motion of the tumor or force shallow breaths. Currently, this is the motion management we're using for abdominal SBRT. And I showed you a picture earlier of our full SBRT body prolock. We don't actually use that for the most part. We like this compression belt that I have here on this patient. It tightens down, can do the pressure, take the gauge, full body bag, wedge under the knee. You'll notice our wedge is actually in the body bag as well. We have that all indexed and marked, pictures taken. And we find when we use compression that this setup works just as well as using our full SBRT board. Now, if we don't want to compress fully with the belt, we'll probably go to the other board to try to mobilize the patient in a more strict manner. Last but not least for motion management is respiratory gating. So by gating, this is where the linear accelerator beam is turned on and off in cycle with a breathing trace. You're going to use the same tool usually used to acquire the breathing trace is used during treatment. So again, you have to have the technology in the treatment vault itself to do gating. You can use a smaller margin if you're only treating during a gating window with little motion. So you'll choose very carefully during the treatment planning time, you'll look at your gating window. I know Dr. Xu talked about this a little bit with thoracic to find the most efficient treatment, but with that minimal motion, looking for probably under that 5 mm margin of motion. It is, again, another loss of efficiency and a longer treatment time, but it's well worth it to have longer treatment times with this high of a dose. You want to get the dose only where you need it. Irregularities in breathing, again, you need to have a good breather, can result in the surrogate, which is that block we place on the stomach or surface guidance. You're using some surrogate, not being in the correct position for the tumor. There are other tools available that are internal motion markers, like a calypso beacon. I haven't seen one of those in many years and didn't really put it into this talk, but for the most part, irregular breathing can make gating difficult. So once you have your simulation, you probably also have diagnostic imaging that you want to use for contouring. So I want to talk a little bit about fusing your images together. You're going to want to fuse high quality diagnostic imaging to help with contouring. This is usually an MRI. It could be a diagnostic CT scan. Maybe you took your CT scans with contrast and without contrast. And you're going to need to move those all together. When you're starting, you're going to always start with a rigid fusion. You're going to use multiple anatomic landmarks to assist with alignment. So here we're looking at liver borders, vessels, bile ducts, intestines, etc. And then after you do an auto match, I like to start with an auto match, you're going to need some manual adjustment following this. If you have access to deformable registration, it can be very useful. Make sure, though, that you understand your deformable registration tool very well, especially if you're using compression, because you can kind of see it in this image where we have our CT scan is compressed, and so this abdomen wall comes in, but the diagnostic scan, they were not compressed. And so everything is very different. So this is an example of an auto match window that I would use. It's centered somewhere near the isocenter of the tumor. So when you're going to do your fusion, especially in the liver, if it's not being done by a physician, if it's being done on the physics and dosimetry side, you want to know where the tumor is, and that's where you're going to focus. Include some relevant landmarks, but you don't need to include everything because that might actually make it harder to fuse where you need it. And go ahead and do a 6 degree of freedom alignment. Rotate everything, roll, pitch, do what you need to do, and have it very carefully reviewed by the physician. And if you can, sit with the physician. So once you've done all of your fusion, treatment planning, contours that typically you're going to want to have in there, and if they're not in there, depending on how your site is set up, either have the dosimetrist and physicist put in the normal contours or call the physician and ask for them. You're going to want all your abdominal, chest wall, spinal cords, cord PRV. If you're close to the cord, go ahead and give the cord a little expansion to feel a little safer about that. Duodenum, stomachs, the bowels. There's not always a GTV. Sometimes there is. Sometimes it's just a CTV when we're in SBRT. And then the two most important, that internal target volume, that is decided from the 4D CT. So you're going to contour your CTV on every phase of the 4D, Boolean them together or add them all together and get your ITV and maybe even add a millimeter to that. And then your PTV. A PTV expansion needs input from the physics side. This is your setup and certainty is accounted for in PTVs. And so this is decided on, well, what immobilization do I have access to? How good is it? How much do I trust it? We've been known to change our ITV or PTV based on how close the tumor is to the diaphragm, because there's a lot of motion there. How well did we compress? How much motion is there even with compression? We attempt to do 40 CTs with the compression belt on just to see how much motion there still is. Of course, you want to contour your kidneys, contour your liver, the liver minus CTV or minus GTV. In your liver cases, this is our surrogate for our normal liver. So that liver minus CTV is what we're going to use for our minimum spared volume, hearts, lungs. And then if you're doing the pancreas case, as you saw, you're going to want to have a GI PRV for all of the motion of your GI tract. If something's missing, just ask for it and get it in there. So these are just some high-level thoughts. I know it's a lot of words, but in bold is the things that is very important. For treatment planning for SBRT, we want a limited volume of tumor with a very high dose per fraction. And for this, hotspots within the target are acceptable and even desirable. So if SBRT planning is new to you, you're usually used to trying to keep a very conformal or very homogeneous dose across the tumor, not an SBRT. You want the hotspot. So the volume of the normal tissue receiving high doses outside of the target, you need to minimize that. You can only go as high in dose as you can spare your normal tissue. You won't want to give too much toxicity with your treatment. So the gradient describing the dose fall off outside the target should be very sharp. And the typical way to do this is to prescribe to low isodose lines. So for example, 60 to 80% isodose line with very small or no margins. So that being penumbra at the target edge. And the rationale there is that high dose fall off outside the target volume will give you an increase in dose heterogeneity within the target. And those hotspots, again, are viewed to be desirable as long as there's no spillage into the normal tissue. Just a word, if you have high dose PTV near a critical organ at risk, for planning, it can be very helpful to crop your high dose PTV away from the critical OAR. So as the physicians contouring their CTV, the CTV and the bowel aren't going to overlap, but once you add your ITV margin and once you add your PTV margin, they very well could. So here's an example where our PTV went into the bowel. And so we cropped it away, and we did actually all of our planning to that PTV OPT, which stood for optimized. We didn't get rid of the the original PTV. We still wanted to look at what's our overall dose coverage, but we focused on the PTV away from the critical structure. And if this is such a concern, and it usually is, that I really got to keep the dose out of the bowel. When you're done, you've looked at your plan and you're happy, create a structure from that dose. So here it is a structure in purple, and it's the 18 gray dose isodose or structure. And now this structure can be sent from the treatment planning system to the console. And your therapists have a guide for keeping the 18 gray dose outside of the bowel. So now when they're setting up the patient and aligning everything, they align the tumor, the PTV, and then they go, oh, nope, the 18 gray line's in the bowel, doctor doesn't want that, and they can shift. That's a really helpful tool if you know there is a certain limit to dose you want to give to the surrounding organs at risk, is make it a structure and send it to the machine. So once that plan's been created, it needs to be reviewed. And some of the big things you should be looking at for a dosimetric evaluation of SBRT plans includes what's the target conformality. We like it to be less than 1.2. It can go up to 1.4 for certain. I used to be a CyberKnife planner, so 1.4 was our metric there. You want to look at your high dose spillage. You want to look at an intermediate dose spillage. The intermediate dose spillage, it's the maximum dose at a defined distance away from the target or by a volume encompassed by an intermediate dose line. And I usually look at the 50%, and see how far out does the 50% isodose line go from the target. And another good index that a lot of these planning systems now calculate automatically is a gradient index, which is the 50% prescription isodose volume divided by the prescription isodose volume. the 100% prescription isodose volume. And ideally, you want to keep that kind of under 4 or near 4. And if it's going much higher than that, really dig into the plan and go, why can we do better? That's just some plan quality tricks as you look through them. Some special considerations from the very physics side, your calculation grid size. The grid size you're using to calculate your treatment plan affects the accuracy of the dose distribution. So here in the US, we know we go by our AAPM task groups. So we use TG101 using an isotropic grid size of 2 millimeter finer. If you're going to go for all of our SBRT, ours is actually 1.5 millimeter is what we do here at Baylor. 1 millimeter or less for very, very small targets, but that's more of an SRS metric. Your normal tissue tolerances are significantly different in SBRT than they are in conventional therapy. That was touched on with that biological equivalent dose. Particular attention needs to be paid to what fraction size, what total dose, the time between fractions. Are you treating every other day? Are you treating every day? So you need to be aware and go through those ASTRO guidelines or the guidelines in your country of what kind of dose tolerance can we do for the treatment scheme that I'm prescribing. And you also have to be aware of your small field heterogeneity calculations. So heterogeneity corrections are extremely important in situations where the target's surrounded by low density tissues. So if you are treating like the dome of the liver, near the diaphragm, near the lung, you're dealing with air, you might want to make sure you're using a Monte Carlo calculation versus a AAA algorithm if you're in ECLIPSE. What QA do we use for SBRT? Honestly, most of the QA physics has to do on the machine is the same for conventional fractionation, but with tighter constraints to account for the high level of accuracy. So on a machine that I wouldn't use for SBRT, I might allow 2 millimeter difference between my table motion requested and measured. But in my SBRT machines, I'm going to keep it at 1 millimeter or 1.5, depending on what my machine is capable of. In addition, any day we are doing SBRT, we do a daily verification of our radiation isocenter. We'll do a daily measurement of our imaging isocenter. This is a picture of a common test for that, a Winston-Letts. Our therapists will run it. It's a plan we have created in their daily QA. And then when physics arrives in the morning, we analyze. Every year and during commissioning, an end-to-end test. And if there is any test that I think is the most important for an SBRT program, it's the end-to-end. That's doing some sort of phantom from simulation through planning through treatment. And it tests overall your system. This is a reference slide, really. It is from the Medical Physics Practice Guidelines in the US, 9.A. I think there might be a 9.B at this point. It's just giving you suggestions for daily, monthly, annual tests with the tolerances. And again, the biggest difference between this and conventional is all of those tolerances are much tighter. For patient-specific quality assurance, there's various ways to accomplish this. You can measure dose with a phantom. You can measure your plans with your portal imager. You can analyze your Dynalogs or your MLC log files from delivering the plan and compare those to the treatment planning system if you have the software that'll do that. We do the first two for every SBRT. We measure with phantom and with portal imager. The measurements of this dose will compare the calculated dose to the measured dose with a gamma analysis. And for our SBRT plans, our analysis passing rate is mandatory at 2%, 2 millimeters. And this was guidance document here is AAPM's TG218. So this is a picture from our New Start liver today, actually. For patient-specific QA, on the left, this is my portal dosimeter. So this is run for every patient, no matter what kind of treatment it is, conventional or SBRT, we do portal imaging QA. with a gamma pass rate of 99. And then on the right, we actually have a phantom measurement that the physicist took last week with the 3D gamma also at 99. That just happens to be a coincidence, but they're usually fairly close. Every once in a while, we catch a difference. So since we have the manpower and the tools, we have chosen to continue to do both measurements. So you do need some image guidance when you're going to treat. If it's available to you, I find it much easier to start with some orthogonal imaging. So take two planar images, KV or MV, perpendicular angles for bony alignment compared to the DRRs. Start getting a bony alignment set up. Then you're going to want to move on to a cone beam. And do think, especially in the abdomen, it's very important to have that 3D match or cone beam CT. So in this situation, you're aligning the patient's cone beam with the CT from simulation itself. And we always use our cone beam CT for final alignment. The reason I showed you that old picture of a prostate is because we do all of our abdominals on our halcyon, which has hypersites. So you can see here on the left, our planning CT and our cone beam CT are very similar. For all SBRT patients, we have a physician and a physicist present at the console for patient setup for every fraction of a stereotactic treatment, not just the first one. If the alignment cannot be matched, we look at, was it indexed correctly? Is there, more filling in the abdomen, depending if they needed to do bowel prep for this type of treatment. And if we just can't figure it out, we cannot get them aligned, we call it off and the patient's going to be resimmed. It is important that every member of your team is aware of setup specifics, including immobilization settings, alignment structures, how to use them. Continuous training is important, and this is for the whole team. So don't forget to train your therapists as well as your physicists and your physicians when doing an SBRT program. Again, if you have KV or surface guidance, do an initial setup and then move to your cone beam. We treat on the halcyon, we go directly to a cone beam CT setup because we don't have KV, or we don't have KV easily. So again, just to kind of wrap it up for my end, recommendations for an SBRT program, very careful commissioning of the machines with stereotactic treatments in mind. And this is of the whole system, the immobilization, your treatment planning system, your treatment plans themselves. You want to decide before you start what is, good plan. And then the linear accelerator you're going to use for the quality assurance. You're going to need a good plan for motion assessment and management. You're going to want to understand what you're looking at for the different motion assessments. Want to make sure that dose calculation grid is less than 2 millimeters. Want to make sure you've got a plan for your image guidance and your QA of your image guidance for alignment. And I highly recommend that at least a radiation oncologist is approving these alignment images prior to every treatment. I didn't go into specialized machines, MR, Linacs, proton therapy. You read a lot about them a lot in research because they are MR is highly useful in the abdominal region, but just not a lot of places have it, us included. So you can do an SBRT program without MR guided machines. You just need to, as Dr. Hanania said, it's going to affect your PTVs. So thank you, and I'll pull up the chat and look for any questions that Baojo didn't get to.
Yes, thank you very much. This is a great presentations. I'm thinking that we can also use this recorded session for our own training for our residents and physician residents. Okay, questions. We're trying to answer questions through chat. For example, I see Kauma has a question for patients with QA analyze log files. Are there circumstances when patient QA failed will resort to log file analysis? Actually, you do. I try and answer the question that if patient QA failed with your portal dosimetry, likely you need to recalibrate your portal imager. The log file, I'm not a big fan for log file for SPRT. To be honest, it's not a direct measurement for your patient delivery. And, it always pass, for example, for variant machine, your log file. Yeah.
Yeah, I agree. We see the portal fail every once in a while, but then the phantom measurement will be spot on. And it's true, a recalibration of your portal dosimetry will fix that. So it's nice. It's one of the reasons we still do both QAs.
For SBRT or radiosurgery, especially when you're starting to implement the program, I highly recommend you using two different ways to measure those. The reason is that it's very high dose, right? You want to make sure, 100% make sure that your delivery is safe. Once you gain more experience, you may be able to, drop one, focus on portal dosimetry. For us, even here, we have many years experience. As Dr. Lafratta mentioned that we use two different ways to do patient care. One is portal dosimetry, which is very efficient, very fast. We also do ion chamber array, imagine 40 dose calculation. It is dose, okay. So any other question? We're running out of time. So we have 2 more sessions left. The next session will be a special topic. We're using SPRT for cervical cancer. I know cervical cancer is a big topic for low and middle income countries, a large number of patient population. And the majority are being treated with HDR and brachytherapy. However, there are some patients which are not eligible for brachytherapy. So here we have a small number of patients treated with SBRT. So next session, we'll only have physician presentation. We'll mainly talk about SPRT for cervical cancer. Then the last session, we are going to give treatment planning demo. Well, given by me and one of our dosimetrists. So if you have interesting case, want to plan demo on your case, please email me and we can. Otherwise, we're going to use our own case. Okay. Any other question? And thank you so much for today's presentation. Really appreciate it. And thank you for joining our training. Geneva will send out the link for the video, and also please provide a simple survey, a quick survey, so we can continue to improve our training session. Okay, if you forgot to register, you can still register or email me or email Geneva, and we will actually make sure that you are registered, and if you complete 5 of the 6 training sessions, you will receive a certificate. Okay, thank you so much. Feel free to reach out to me or our speakers, and we're trying our best to answer your questions and provide support to you. Okay, thank you.